Hi, everyone. We've got an amazing presentation coming our way by an amazing presenter, Dr. Daniel Juneau. He'll be talking to us about the Theranostics at CHUM, clinical research integration and teamwork to improve patient access. Dr. Daniel Juneau is head of nuclear medicine at the Centre Hospitalier de l'Université de Montréal, CHUM, medical director of the cyclotron and radiochemistry unit of the CHUM Research Center, and an associate professor in the Department of Radiology, Nuclear Medicine, and Radiation Oncology at Université de Montréal. Dr. Juneau's research interests are focused on radioligand therapy and new theranostic approaches, including phase 1, phase 2 studies of new theranostic molecules, as well as developing new clinical approach to facilitate RLT adoption and integration into clinical workflow. So without further ado, Dr. Juneau, the floor is yours.
All right, well, thanks a lot for the nice introduction, and thank you for inviting me to speak here tonight. It's a pleasure to be here today. All right, so let's get started. Theranostics at CHUM, clinical research integration and teamwork to improve patient access. So first of all, disclosures, I have received honoraria and done consultant work and/or received speakers' fees from Novartis, Ipsen, and Spectrum Dynamics, all of which is not directly related to tonight's presentation. Objectives. So tonight we're going to try to illustrate how to build a Theranostics program from the ground up and optimize an existing one. Demonstrate strategies and tools to make your program more efficient, patient-centered, and sustainable, and try to identify and avoid common operational and clinical pitfalls in Theranostics practice. What this is not going to be is a review of PSMA Theranostics or PRT, as this is going to be really tracer-agnostic, or anyway, as much as possible. All right, so first, I'm going to start by introducing and presenting the Theranostics program at CHUM. So our main objective when we set up the program was really to improve patient access to Theranostics, because this is what all of this is about. It's delivering great quality care to our patients. And at CHUM in Montreal, we are very lucky, as you're about to see, because we have all the pieces. We have everything we need, truly, and it's all about putting all that stuff together to make it work as a whole. So a little presentation of the CHUM and its nuclear medicine department. So this is a very nice picture of the CHUM in downtown Montreal. It's the largest French-speaking hospital in North America. We have one of the largest nuclear medicine departments in Canada. We have 12 full-time nuclear medicine physicians. We have 7 SPEC CTs. 6 of those are traditional NAI system. One is a more recent digital full-ring CZT SPEC CT system. It's a Veriton 300. It was the first of its kind to be installed in Canada and one of the first to be installed in North America. There's 3 PET CT at CHUM. 2 of them are physically located within nuclear medicine. The third one is in radiation oncology physically, because it is used, amongst other things, to do radiation therapy planning PET. We also have a cyclotron. We have 4 inpatient treatment rooms, 5 outpatient treatment rooms. We have a dedicated RLT nurse, and we have dedicated physicists. So we have a lot of stuff. When it comes to isotope production at CHUM, so that's a picture of our cyclotron. So we have a cyclotron, we have a full radiochemistry lab and platform, but we are mostly focused on the production of diagnostic radiotracer when it comes to the in-house production. When it comes to therapeutic radiopharmaceuticals, we mostly do those through collaboration with industry. And the decision was driven by 2 main arguments. The first one is our local expertise. Our radiochemists and our whole team has more experience working with diagnostic tracer rather than therapeutic. But the other decision was that we felt that was where we were getting the better bang for our buck, because developing those therapeutic radiopharmaceutical can be quite expensive, and you need deep pockets to do that. And who's got deep pockets? Well, big pharma. So that's how we're doing it. When it comes to diagnostic tracer, we're very lucky. So the cyclotron is located right here under the entrance, the main entrance of the CHUM Research Center. And there's a dedicated pneumatic system that delivers the radiopharmaceutical directly from the cyclotron unit to the nuclear medicine department, which is on the 8th floor of the main pavilion right here. So that takes about 48 seconds. Or we can also send radio tracer to the animal lab at the CHUM when we're running animal experiments. All right, so as mentioned in the title, we are truly trying to integrate both the research and the clinical work together. So what does this mean? This means that the majority of the nuclear medicine infrastructure at CHUM is used both for clinical work and research work. This, we believe, is more efficient and facilitates the translation from research to the clinic. Of course, it comes with added complexity in terms of management, in terms of scheduling, but we do believe that the payoff is worth this extra investment. And it's a bit of the same with human resources, with staff. So a significant proportion of the staff is also shared between the clinical work and the research work. Again, because we believe that's more efficient, and in large part because it facilitates the knowledge transfer. It really makes it seamless to go from research to clinic when you're working this way. Another thing that we've got that helps tremendously is the Unit for Innovative Therapies, or UIT. So this unit is a clinical core facility at CHUM and CHUM Research Center that specializes in early phase trial. It's basically a mini hospital within the hospital. It's a full unit and has 16 beds, both inpatient and outpatient, and it regroups more than 50 investigators and more than 40 full-time staff, including admin staff, nurses, lab staff. And what it does basically is it offers full turnkey services for phase 1 studies and phase 2 studies. So they will basically, you can go to the unit and with an idea, right? And they will accompany you from a project startup up to patient recruitment, clinical service, clinical care, and even study monitoring. Okay, so really it's transversal and has hosted more than 70 phase 1 studies since its inception in 2019. Is the only facility of its kind in Quebec. And what it has really allowed us to do at CHUM and CHUM Research Center is it has allowed us to develop really a team that is really competent and really comfortable with running these early phase trial. Because oftentimes what will happen is phase 1 studies, they have this extra layer of complexity, this extra layer of monitoring, and there's really a lot of extra hurdles when you're running early phase studies. And your regular research team is only going to be running a very limited number of these phase 1 study, right? So for example, if you take your prostate cancer team, they're not running 20 phase 1 study, they're running 2 or 3 at most, right? And what happens is, if you do it that way, nobody ever gets comfortable running these early phase studies. By concentrating this volume of early phase studies in one unit, it has allowed us to really dedicate staff to very specialized tasks and to develop this really high level of experience and expertise in these early phase studies, and it has really paid off, I do believe. And this is just to give you an example. So this is all Theranostics and RLT. These are all studies that we've had the chance to recruit patients for at CHUM in nuclear medicine over the last 7 years. Quite a few. Everything that's bolded is a first in human. We've had the chance at CHUM to actually do a few first in human worldwide, and really it's been a tremendous experience working with the whole team on this. And I think that I speak for everyone when I say we're quite proud of what we've achieved, and we've been having a blast. So another aspect that's very important that I already mentioned is we have a dedicated RLT nurse. We were the first center in Quebec to have a dedicated RLT nurse, and I think we're still the only one to have one, although that may change quickly. So she basically acts as some kind of pivot nurse for RLT patients. So of course, she is giving clinical care, but also acts as a first point of contact in a lot of situations and plays a very crucial role in patient education, which we'll get back to later on in the talk. Another very important aspect of the Theranostic program at CHUM is training. So we are lucky, CHUM and Université of Montréal has the largest nuclear medicine training program in Quebec. And we make a conscious effort to ensure that every resident that trains in our program is not only exposed to the clinically approved theranostics, so they're doing PRRT, they're doing PSMA lutetium, they're doing iodine, radium, but they're also being exposed to research theranostics. And really the main objective here is we want a trainee that finishes their residency here at University of Montreal to be entirely autonomous upon graduation. They should be ready, given the adequate resources, to start their own theranostics program. In addition to resident training, we also offer an RLT preceptorship, which is aimed at in-practice nuclear medicine physician. A few of the attendees tonight have had the chance to undergo this preceptorship. It's a mix of classroom and hands-on experience. It lasts 2 to 3 days, depending on what exactly you want to cover. And we really walk the attendees, the preceptees, we walk them through the whole process from patient selection, patient imaging, treatment, how to set up, treatment follow-up, and everything in between. And lastly, to round this up, we are about to launch a new Theranostics fellowship. Hopefully we'll have our first fellow later this year. And this is, I believe, going to round up really the whole training aspect. And I think that this is really critical because in general, Canada and Quebec and Montreal have been very good at participating in trials over the last few years. But at this point in time, it's crucial that we give good training and good education, both to the nuclear medicine community and to the referring doctors, to really get theranostics out there and to grow it into the great, to grow all its great potential. All right. So this has covered the Theranostics program at CHUM. Or anyway, described it in a good overview. So now let's look at the patient. Let's look at a typical patient journey at CHUM. So this is what it looks like. So the first step is a requisition is received by nuclear medicine. We have dedicated requisition. I'm going to talk more about that later on. So we receive that. First, the admin staff is going to go through the requisition first, right? They make a first check. They verify that the file is complete. They have a checklist to follow. If they're happy with it, they send it through to a nuclear medicine. So the consultation gets assigned to one of the nuclear medicine physician, which now reviews, does a more thorough review and makes sure that we have really everything that we need. If anything is missing at that point, we're the ones, so nuclear medicine is going to order any additional testing that we need. For example, there's some blood work missing, or the nuclear medicine physician believes that some extra imaging is necessary, so we'll order that ourselves instead of asking the referring doctor to do it, right? We're trying to cut down on intermediaries. Once we have everything, we're going to proceed with a consultation. This consultation is usually going to be in person, but we also do telemedicine when it's more convenient. And then after the consultation, if we judge that the patient is a good candidate, then we'll move on to a tumor board presentation for the vast majority of patients. Sometime this will have happened before, because often it will happen that patients, they get referred to somebody else in the larger CHUM environment, right? And whoever that is, might be a surgeon, might be a medical oncologist, they decide that RLT Theranostics is the way to go, and they send it to us, right? And only once all of that is done will we book a patient for the actual treatment and order a radiopharmaceutical dose for whatever they're getting. So moving on, we're gonna do a deeper dive on these questions. So these are all important questions that will need answers before you get started. So first question, where and how will you receive requisition? Second question, who's going to be in charge of pre-treatment workup? Third questions, where and when will treatment take place? Fourth one, who's in charge of monitoring during therapy? Fifth one, are you going to be doing post-therapy imaging? And sixth one, who's in charge of coordinating all of that? All right, so let's get started. First, the where. So facility layout and design. Of course, having a dedicated therapy room is the ideal setup. But if that's not possible, if you're in a smaller center, well, no problem, because the shielding in any regular nuclear medicine room should be more than sufficient to handle some lutetium-177. We're lucky that the half-value layer in lead for lutetium-177 is only 0.5 millimeter, right? So it's relatively thin compared to what we're usually working with when it comes to gamma rays and positron emitter. And so even if needed, you can even use some portable mobile shield. They can be useful and not too expensive if you need additional shielding, right? And things are going to be even easier when it comes to actinium-225 if eventually you move on to using that, because it's mostly alpha, right? And the last tip I can give you is be very generous with the absorbent paper when you're getting a treatment room ready, right? We are extremely generous with the absorbent paper. We'll put it on the working table, we'll put it on the floor beside the stretcher, we'll put it everywhere, right? Because the last thing you want when you have limited rooms available for treatment is to have to stop working somewhere because there was a contamination, which is unlikely, but may happen, right? Still looking at facilities, the bathroom, okay? So if at all possible, you should definitely try to have a dedicated bathroom for therapy patients, particularly if you have dedicated treatment days, okay? So you got to remember that with some of these Theranostics tracer, up to 50% of the activity is going to be eliminated in the urine in the first 6 hours after therapy. So there's cases where that's not too critical. For example, if you're doing PSMA lutetium, most of the time the patients, they're not going to stick around for a long time. But if you're doing PRT and patient is staying 4 hours after treatment, they're going to need to pee. They're going to need to use the bathroom, right? The best scenario is you have a dedicated bathroom adjoining the treatment room. If that's not possible, you try to dedicate a regular bathroom that's as close as possible to your treatment room. You try to dedicate it for treatment patient on the day of treatment. And the last case scenario is you just use any old regular nuclear medicine bathroom. But really you're trying to minimize the patient's movement around your department, right? Once they've been injected with 200 millicuries, for example, of dotatate lutetium-177, you don't want them wandering around looking for the bathroom, right? The other thing to keep in mind is that the bathroom is by far the most likely place for significant contamination, right? So you got to be very careful. You got to watch out for little droplets that get projected when flushing the toilet. Quite a few of our hospitals, they have these industrial grade toilets, right? Where you flush and there's this explosion of water that sends little droplets full of lutetium laced pee all over the place. So you want a cover on your bathroom, on your toilet seat. Oftentimes in hospitals, there's no cover, right? But ask your maintenance people to have one installed so that you can actually put it down. And a nice little tip, on the start of a treatment day, make sure that the toilets works properly, meaning that there's no clog. Like, go in there and flush the toilet to make sure it works, because you do not want to discover that it's clogged while it's overflowing with lutetium-laced urine. And so to sum it up, when it comes to the planning of the actual spaces you're going to be using, you'll need to involve your RSO, your radiation safety officer. Involve them early on. You'll need to determine what exact local measures will be required, and there's no one-size-fits-all measure here. Your setup, your actual room placement, your volume of activity, how long the patients are going to be staying, all of that is going to play into what measures you need to put in place. And you need to be ready for a spill, because no matter what you do, you can take all the precautions you want, there will eventually be a spill. So make sure your team is ready to handle that. A bit earlier, I mentioned treatment-specific requisition. So this is an example of one such requisition. This is the one that we use for PRT. As you can see, it says PRT right there. This is in French, of course, because we're in Montreal. But basically, it's check mark, right? There's an area for patient ID, clinical information, and then just a few questions where they check the appropriate one. It's the stuff you would expect, like is a pathology report provided? Yes, no. As the patient, when was the last take PET, and so on. You know, the really easy stuff. Takes about 3-4 minutes to fill it out. Initially, when we rolled those out, there was some mild pushback from some of the referring clinicians, right? They were saying, oh, this is long. Why do I need to do this? But it helps everyone, because basically it helps both the referring physician and the nuclear medicine team in diminishing the number of inappropriate requisition, and it helps to quickly identify more urgent cases. And yeah, sure, there was a little pushback initially, but once people see that this tool actually works and helps them, then they get on board with the program. And as soon as people got used to it, we haven't had any problems since then, and I highly recommend working with something similar. So the theranostic consultation, I'm not going to read all of this, but basically that's a crucial step. You of course you need to see the patient. Of course you need to go over their complete medical history, because you're going to be the one making the final call on who's eligible and not, right? And you're the expert, so you absolutely need to get in there and get involved with the patient. When it comes to the treatment, we've also developed standardized treatment prescriptions. So this is an example. Again, this one is from PRT, so you can see what it is. It's in French again. But basically, it helps to just streamline the process and avoid mistakes. So there's a section here for antiemetics. There's a section about the amino acid. And so basically, when we're planning a treatment, it goes very quickly, and we just check whatever we need. I'm not showing the whole thing here, but again, it's about having these tools that will help to keep everything organized and to minimize mistakes and little human errors. So a typical treatment on the day of, this is how it's going to be. So first the patient will arrive, and I've indicated who's doing what, basically, in parentheses. So a patient will arrive at the nuclear medicine department. There's going to be some admin staff to greet them. Then they will be installed in a dedicated treatment room, here at CHUM anyway. That's going to be done either by a tech or by a nurse, depending on who you have available. Put in an IV, take the vitals if you need to, and then move on to the pre-medication. If there's pre-medication, then the MD steps in, because we always give the final go-ahead. We always assess them just before the treatment to make sure nothing has changed, and we give the final go-ahead. So the total time in hospital is going to be, it is going to vary, right? From 30 minutes for PSMA lutetium-177 to up to 5 hours for lutetium dotatate. And again, with the tools that we've developed, so on the day off, to facilitate the process management, we've developed a shared checklist. So this is on the day off, and it walks you through the treatment. So it It asks basically, so again, this is the one for PRT. So it says, okay, so the patient is here for dose number X. Have we checked his latest lab? Were they okay? So check, check, check. Have we done the double verification of the ID? Have we given the pre-medication? Have we given the amino acid? When did we start them? Have they been going for at least 30 minutes? And so on. So we have this checklist. And really, good organization, we think that good organization is key, particularly if you're treating more than one patient in a day. And you'll want to stagger their treatment start time to facilitate your team's work. So I need a little word about adverse event. Quite a few in common with other oncological therapies. So, you know, the usual suspects, fatigue, nausea, medullary suppression, those are nearly universal when it comes to oncological treatment. Some are going to be treatment specific, of course, like xerostomia for PSMA. So basically, they will happen. If you treat enough patients, you will run into adverse event. What's important is you need to have a discussion ahead of time. You need to decide early when you're setting up your program, you need to discuss who will deal with what and where. So speaking for CHUM, we deal with most of the simple stuff. So for example, if a patient has nausea following their treatment, we're going to be in charge of that. But if somebody following a treatment gets to the ER and they have febrile neutropenia, I'm not going to take care of that, right? This is a serious complication. I'm not really trained to deal with febrile neutropenia. Med-onc is going to deal with that, because if you're dealing with that, you want an actual expert. So you need to have these discussions with your referring doctors and your institution at large to determine how it's going to happen, because it will happen. Post-therapy imaging. So up until recently, we did not image every patient at every cycle because of the burden it represents on imaging resources. So for the last few years, we were mostly doing post-treatment imaging if there was significant toxicity, right? Because if your patient is experiencing a lot of toxicity, you want to make sure that it's for a good reason. You want to make sure that he's responding. We would also image anyone who had a clinical progression. So for example, patients in PRT who have a carcinoid syndrome and their symptoms were not getting better, they were actually worsening, and you're wondering, is it just interference for the treatment? Is it actual progression? So we would image those patients, and we would image anybody that we considered to be at a risk of dedifferentiation. So for example, anyone with a high-grade tumor or discordant lesion on their pre-treatment imaging. But at this time, we're actually moving to imaging at every cycle, and that's really thanks to the shortened acquisition time with our new full-ring CZT SPECT-CT. It's really been a game changer. I'm going to show you how much of a game changer. So these are images acquired 24 hours after the injection of 200 millicuries of lutetium-177 PSMA. So this is whole body acquisition, SPECT-CT, 45 minutes. Images are pretty good as far as I'm concerned. Not too much noise. You can do great dosimetry on these images. They're good, but it's 45 minutes. There's recent literature showing you could shorten that, right? You're going to degrade the image, there's going to be more noise, or you can introduce some tools, but you're never going to make that a short acquisition. But this is what you can do on one of these recent CZT system. So this is another patient, it's not the same. Images were performed 24 hours after the injection of 200 millicuries of lutetium dotatate, and this is 10 minutes for a whole body scan. So really, it's been a game changer, and thanks to that, we're now moving towards a lot more post-therapy imaging. And I think it's going to be useful in quite a few patients. And what has allowed that really is the new system. It's the combination of the hardware and the dual peak imaging. It really allows for major reduction in imaging time while maintaining excellent quantitative aspect. So in between cycles, you will be doing clinical follow-up with your patients, of course. So who and how much? So what we do is we do a short phone call the day after treatment, right? That can be done. It used to be done by the MDs a few years back before we got the nursing staff. Now the nursing staff actually does that. They call every patient the day after their treatment just to make sure everything is going well. They're hydrating well. They don't have any last minute question, particularly on their first cycle. So we make a short phone call. If needed, if there's any questions that the nursing staff cannot answer, then it goes to us, of course. We always recommend that the patients keep up their regular follow-up with their referring physicians. This is particularly true when patients are referred from outside the CHUM, because we know that we're going to be treating these patients for a little while, right? A few months, most likely. And then we're going to be sending them back to their original team, be that a surgeon or a med-onc or a radiation oncologist. And we don't want whoever that is to have completely lost track of their patient. So we really encourage the referring doctor to at least keep up a regular follow-up with their patient. There's going to be blood work after each and every cycle. This is ordered and assessed by nuclear medicine because you want to be front row in following your patients while they're under treatment, of course. Now, I've mentioned that already, but I really want to spell it out. Teamwork is crucial as far as we are concerned at CHUM when it comes to Theranostics. Theranostics is a complex process. It requires staff coming from a lot of places. There's going to be admin staff involved. There's going to be medical staff. There's going to be pharmacy staff. There's going to be nursing staff. There's going to be nuclear medicine technologists. Communication is key. If you want this to go smoothly, you need to be speaking with each other, and good communication and good tools will help with that. And I cannot overstate this, but I do believe that a multidisciplinary approach is crucial for these patients. Most of the cases we see in the Theranostics clinics, they are complex, they're advanced, right? It's rarely used as a first-line approach, right? So most of these patients will already have had at least one, probably more than one systemic treatment. Most of them will be or will have been in the past discussed at tumor board, and their care will involve specialists from nuclear medicine, medical oncology, radiation oncology, surgeons, radiology, endocrinology, name it, right? So, and I think that this is key to deliver high quality care to our patients. All these people need to be talking to each other to ensure that we are treating the right patient the right way at the right time. And as I mentioned earlier, who coordinates all of this? There are a lot of moving pieces and the logistics are complex. When you're setting up your program, you will need someone that has a good view of the whole process. If you don't have this person, and I'm not saying like it can be anybody or nearly anybody, right? But you need someone whose job it is to look at the whole process and make sure that nothing falls between the cracks, because otherwise mistakes will happen and doses will be wasted. So I'm coming towards slowly building to the end of my presentation. And one thing I really wanted to discuss is the patient's point of view, because we must never forget about the patient, right? This is all about them. This is about giving good, high quality care to the patients. Our experience at CHUM in Theranostics has been that most patients are really unconcerned about the exact mechanism that underpins their treatment, right? The treatment acceptance and tolerability is often as important as the treatment efficacy, particularly when you're looking at palliative treatment, right? When you're approaching someone and you have a curative treatment, then that's different, right? But most of the time, Theranostics, we're not in the curative, or anyway, it's rare, it's uncommon. We're mostly looking at extending life, maintaining quality of life, it's palliative, right? And so oftentimes they will have a lot of question about that, about tolerability. And I think the best, we see that often, I would say, particularly for Pluvicto in the last few years, patients that come in, they haven't had chemotherapy and they really want to get PSMA lutetium 177. Why? not because they think it's necessarily a lot better than chemotherapy, but because they think, rightfully in most cases, but they think that it's easier to tolerate. And the data supports that, but that's very important for these patients, right? Quality of life. So you got to keep that in mind. And you got to ask yourself, from the patient's point of view, what's different about Theranostics? Well, it's not the treatment regimen, right? Because that's very similar to other systemic therapies, right? It's outpatient, takes a few minutes or a few hours. There's an IV, there's pre-medication, you see a lot of people. Okay, so that's normal. What's different, it's what's comes afterwards. It's the radioprotection, basically. When it comes to radioprotection, from the patient's point of view anyway, most patients, I would say 99% of patients, they are unconcerned about their radiation exposure. I say 99% of the time because there's going to be, nobody is in, my experience has been, it's quite uncommon for people to be somewhere in the middle. Either they don't care or they care a lot. But what most patients are going to be concerned about is the exposure of their loved ones and their pets, and the impact that this is going to have on their quality of life. They are concerned about the radiation protection measures, particularly isolation, right? If they need to keep away from their loved one, right? If they're going to be missing important life events like their son's graduation or a wedding in a family or any of these important milestones, and that's going to be important for the patient. And what's also going to be important is treatment regimen, but that's, I would say, mostly to our advantage, because when it comes to Theranostics, most of the approved therapies, they're spaced out by quite a few weeks, so that's good. Patients like that, right? Not to have treatment every 2 weeks. And so again, going back to your radiation safety officer, this is also something you'll need to talk about. You'll need to discuss your radioprotection measures and to discuss contingency plans, right? Ideally, my advice is you should give patients both hard copies and electronic copies of their radioprotection directives, right? And give them a wallet card. So this is just an example. So again, we've developed tools for that. So we have these nice radioprotection summaries that we give out to the patient. So this is the one for lutetium-177 tracer. It fits on one single page. We try to keep it as simple as possible, use language that's very clear, very easy to understand. And of course, it's going to revolve around the two cornerstones of radioprotection when it comes to the public: physical distancing and excreta management, right? Of course, the exact measure that you're going to be giving to one patient is going to vary depending on what exactly you gave them, the isotopes, and the amount, of course. And this is the last piece, the wallet card. So I strongly advise that you either make your own, or some of the therapies that are approved already have some that are pre-made that you can use. We've decided to build our own. This is what it looks like. Again, it's in French. Well, actually, no, this one is in French and English, because we advise the patients to take it with them when they're traveling, to actually keep it in their wallet on them at all time. And it includes basically the patient ID. It gives the emergency phone number for radiation safety, and it includes what treatment they've received and when and the activity. This is the one for lutetium-177 radiotracer, radiopharmaceutical, right? And so this, again, is going to be a tool that you need to make your own. Yeah. Patient education is also going to be extremely important. It is critical that you warn patients of what to expect. A few minutes today when you're doing the consultation, explaining to them what's going to happen is going to save you a lot of time down the line. And another tip that I can give you is you should encourage patients to use their prescribed medication, for example, antiemetics, even if their symptoms are only mild. That will spare you some non-urgent emergency visits. And make sure that there's a way for the patient to reach your team, right? Make sure that they have a relatively easy way to reach you or a designated member of the team with their concerns and their questions, right? That could be by phone, that could be by email, because the patients, they will have non-urgent or semi-urgent questions, right? And if you make it easy for them to reach out to your team and get the info they need, you'll avoid unnecessary ER visits and potentially even catch some adverse events early on before they become too serious, right? But no matter what you do, as I mentioned earlier, even if you are extremely well prepared, eventually stuff will happen, and be ready to answer some questions coming from your ER staff, and even do some follow-up consults for your patient in the ER. We've had that happen quite a few times. This is also one of the entry point for your patient. So if you're starting a new program, a heads up to your ER team is actually advised, because eventually they'll have one of your patients coming back 2 days after PSMA lutetium treatment with myocardial infarct, for example, and then they'll be like, okay, what do we do with this radioactive patients, right? So give them a heads up and let them know you're here and you can help. So I'm going to finish up with a look forward, a look at the future. And so what do I think we need for success? First, I think we need patient acceptance and education. We need to continue building good educational material. The CNM has been quite good at that, actually, and I think that overall the community has been very good. Nursing staff, I think, can facilitate this educational portion of the program tremendously. Then we need Theranostics to be available, and we need good ease of use. And by that, I mean better logistics. But that comes, I think, in large part with the scaling up. We already see that the logistics are just getting better, right? I also think that we need better pharmacoeconomic data. The best example I can give of that is Pluvicto. Pluvicto got provincial reimbursement in Quebec only a few weeks ago. Like, that's just too long. It took nearly 3 years. The scientific data was there from day one, but we would, I think, if we'd had better pharmacoeconomic data, we could have shortened that time by a lot. And that is, I think, an area where as a community, we would do well to put a little more effort on that side of thing. I think we need to keep building on that multidisciplinary approach. I truly believe that at CHUM we've been doing a really good job of that, but I'm sure we could do even better. And I think it's time to start exploring combination therapy, because up to now, Theranostics has been mostly used in a monotherapy approach, but we see it in the research world. It's slowly happening, but I think we are at the stage where it's time to start exploring these combination therapies. I will finish with a big thank you to the entire team at CHUM, with particular thanks to Dr. Malia, Dr. Morin, Dr. Pluznikov, who have also been instrumental in setting up the Theranostics program. And I will now be quite happy to answer some questions.
Amazing presentation. This was very, very interesting. I do have to say, as a member of the CHUM team, one thing I appreciate the most is how well this works. And when things work well, the logistics, honestly, you're able to treat so many patients, and even the attending experience is outstanding. So let's start off with some questions. So I'll start off by the one sent first, and we'll go in order. So what advice would you have for small remote sites attempting these therapies and scans? 2 cameras, only one with CT ability, no access to PET, rely on delivery of radiopharmaceutical, currently serve 400 patients a month for all nuclear medicine tests, no dedicated washroom or therapy rooms available.
Well, that's a tough one, but I think the main point here is, as I explained, So you won't be able to do it all, right? I think in a situation like that, you need to start make sure that what you're doing well. So don't try to do everything. Don't try to get started with everything at once, because that's going to be overwhelming, and that's not going to work well, right? Start with a little piece, do that piece well, and then build on that. Definitely in a scenario like this, you need to have some kind of official or semi-official um, uh, deal in place with a center that has access to PET, right? Because you'll need PET one way or another. So I would definitely be exploring that option. And then look at how you can reuse what you have. Even if you have limited facility, as I explained, if you're not doing a high volume of these therapies, if you're doing a relatively low volume, which is what I assume a center of this size would want to do, then you can try to, repurpose some of the existing facilities, even if it's temporarily. As I said, the high value layer for lutetium is quite low, so you don't necessarily need these dedicated space. You need them if you want to have a program that's treating hundreds of patients a year. But if you're doing a few a month, you can probably manage by repurposing what you have.
Right, next question. It's a bit more on the RLT preceptorship. Is there any chance to offer some of it virtually? And yeah, I think it's essentially.
That's a very good question. Up to now, we haven't. We would have to do things differently. The way the preceptorship was built, it's really meant to be in small groups, and it's focused a lot on interactions with the attendees, and we personalize the delivery to every center that comes through the preceptorship. And every evaluation of it we've had, people loved it. And we could not just take the same content and put it online. A lot would be lost, right? It's really about there's a lot of hands-on stuff in the preceptorship. Like, the groups are limited to 5 people. We're not just trying to do another talk and not that I have nothing against webinar, right? We're doing one right now, and I think that's a great tool, but there's a place for something that's a bit more in-depth and personalized, and this is what that preceptorship is. It's really meant to be a deep dive and to take you, and you come to us, and we really walk you through this process. And when you leave, I guarantee you're going to be a lot more comfortable.
Do the hospitals need to have dedicated decay tanks to store radioactive waste, mainly urine, for the toilets before the waste is discharged to local municipality lines?
So the answer to that is not in Canada. There's places where that is the case, but not in Canada. In Canada, basically, anywhere where you have a regular public sewage system, it's the dilution principle. So basically, patients, they are allowed their excreta, the patient's urine and feces, they're not considered to be radioactive material per se. They're considered to be medical waste, right? And so they're allowed to just use their bathroom, use their toilet, and flush it down. What they would not be allowed to do, for example, as a kind of a caveat, like, let's say you could not do urine collection at home. Like, you could not tell a patient, collect your urine and bring it back for whatever reason you would want to do that. You're doing a dosimetry trial or something. Now, that's a lot more complex. But when they're just using their bathroom, using their toilet, that's fine. It's dilution. That's the idea here.
Do all spills of lutetium-177, are all spills of lutetium-177 dealt as major spills?
Not necessarily. It's the same rules as with other isotope. Depends on the amount. most of so first of all, the main ones, dotatate lutetium and PSMA lutetium, they're not very volatile, so that's good. So already that's a point in your favor. So it really depends on was someone involved, right? Of course, if you spill something on someone, then it's a major spill by definition. If it's on the ground or a surface, then it really depends on the amount, and it's just like any other isotope. Yeah, yeah.
Are you doing post-treatment imaging for all cycles of Pluvicto?
So yes, that's what we are now doing, but not necessarily what we did in the past, as I said. But yes, going forward, we are moving to imaging every single Pluvicto patient at every cycle, one time point. One time point, yeah. For PRT, we're still playing around with the imaging schedule because the evolution is a lot slower, right? So some patients are probably going to get imaged at every cycle, some only at every second cycle.
I saw a 200 millicurie dose injection of lutetium. Isn't that a high dose?
No, that 200 millicuries of PSMA lutetium 177 would be the standard dose for PSMA, for Pluvicto, let's say. And if you're doing PRT, and again, if you're doing Lutathera, which is the only commercially available PRT in Canada, the standard dosage is 200 millicuries. So that's really standard dosage. Yeah.
For the follow-up, apart from post-therapy scintigraphy performed after each cycle, do you carry out a reassessment after second, fourth, and sixth cycles with PSMA PET and FDG PET to evaluate the response and search for dedifferentiated disease?
So the answer to that is we do not do it systematically. We will do it in targeted cases, either because there's some clues that are letting us suspect that there's progression, that there's something wrong going on. That might be from the post-therapy SPECT CT, that might be from the biochemical or the symptomatic side, but we don't do a midway, because some centers do that. I'm aware of that. Some centers, for example, will do a repeat PET PSMA after cycle 3 of Pluvicto. We don't do that systematically. If I had unlimited resources, which I don't, maybe I would, but I don't think it's necessary, not when we have limited resource in a public health system and there's a lot of people waiting to get a PSMA PET CT. So the answer is not systematically. We'll do it in targeted patients when we have a reason to believe that things are going off script.
We have time for 2 more questions. So what is your management plan in case of extravasation during treatment with lutetium 177?
Excellent question. So first of all, these are not given, these are not flushed, right? These are given slowly intravenously. So first of all, is minimize the chance of extravasation. So the way you do that is we test the IV extensively. When it comes to PRT, we actually, like, the patient comes in, they get their antiemetic, they get their amino acid. That takes an hour, right? So during this hour, on the one arm, they're getting their pre-treatment drugs. On the other arm, we put an IV for the actual PRT, but we have saline going through that for an hour, right? So if it's infiltrated, you'll know, okay? When it comes to Pluvicto, we don't have an hour to spend, but we put in the IV and we test it right away. And we test it for a few minutes. And then when I get in there to do the treatment, I test it one last time with 10 or 20 cc's of saline all the time. So it should not infiltrate. And then we do the injection slowly, right? And if you have any whatsoever doubt that you have infiltrated, you stop, right? So that's the first thing. Since you're not pushing this in, you should not infiltrate a large amount of it. But now what happens if you do? Okay, so if you do not try you don't try to suction it out. That you don't do that. Okay, you don't want to do that. These tracers, they are long half-life. Even if you infiltrate, they're going to be reabsorbed by the lymphatic system, right? So in terms of efficacy, even if you infiltrate the dose, you should get the full efficacy. The only worry you should have is a local reaction, right? With beta emitter, these are very rare because even with a few hours of hanging around in the subcutaneous tissues, the resorption is quick enough. There's usually not going to be enough damage to cause any kind of necrosis, or it would be very unlikely with lutetium, with the small amounts that you're likely to have infiltrated. When it comes to actinium-225, that's a little bit different. You could, in theory, see some necrosis. So the answer is, if you infiltrate, let's say it's an arm, you want to put the arm up, you want to put some warm compresses to open up the lymphatic and to facilitate the resorption of the tracer, and then you want to do a close follow-up of that. But you do not try to suction it, because that's just what you're gonna do is just, you're gonna hurt the patient and you're gonna just break down the tissues. You're not helping.
Last question. You mentioned that you have a dedicated RLT nurse. Please expand on why you chose to have an RLT nurse rather than a RLT technologist.
That's a very good question. Well, because there's some, so I would say my experience has been nurses are going to be a lot more comfortable with everything that's non-radioactive drug, right? So handling, particularly if they're coming from any kind of oncological background. So all of these assessment, follow-up, answering patients' questions, our technologists, they're pretty good, but they don't have that level of expertise in terms of patient follow-up, right? And what's more, if you manage to score not just a nurse, but a nurse with a bachelor, she actually can do a lot more. So for example, okay, let's say the blood work in between cycle, okay? So with a registered nurse, basically you can give them guidelines. You can tell them, look, if the hemoglobin is at least 100, that's good for me. I don't need to see it, right? So you can do that with a technologist. They cannot make that kind of call, but a nurse can. So they can do a lot more in terms of patient follow-up, basically. That's the answer. When it comes to the day of treatment, you could argue a technologist would be able to do most of the same stuff, but when it comes to patient follow-up, a nurse can do more.
Perfect. Well, this sums it up for the Q&A. So, Dr. Juneau, thank you so much for the presentation. It's always a pleasure to have you talk to us in the CANM, and it's an honor to be able to moderate this session and to be your colleague at work. So for everyone, I hope you've learned a lot, and I mean, Pluvicto is starting to get reimbursed slowly in every province, so we're ready to give patients the best care, and if ever you need anything, we have the preceptorship and we are available to help you start off your programs.